And basically we just wanted to start this off with a general introduction to oncology rehabilitation. So just for some general objectives that we had shared, we want to have some tips and tricks on how to get involved in oncology rehab. Any questions related to just deepening our understanding of oncology rehab, as well as ways to get involved, whether you're a student or a new member, and what that looks like. So Dr. Stockwell, we're so excited to have you.
Yeah, happy to be here.
Yeah, so if you could just tell us a little bit about yourself, maybe where you work, how long you've been working in the oncology population, and any fun facts about yourself.
Yeah, no, absolutely. Thank you so much for having me. So yes, my name is Audrey Stockwell, and I am physical therapist, certified lymphedema therapist. I work at Court Physical Therapy, so that is located in Louisville, Kentucky. So, and you have to say it Louisville, Louisville. So, anyways, but that's where I'm at. I work for Revital Cancer Rehabilitation is kind of our nationwide branch. Court is owned by Select Medical, so I'm the director. I'm our Revital Cancer Rehab Program Director for Court. That role just kind of entitles, I basically run our cancer rehab program for Kentucky and Southern Indiana. And as far as oncology, I've really been working in the oncology space for 20 years in the sense that I call it kind of my grassroots. I started really when I was in PT school and then graduating, learning as I went. But I've really focused my career on it probably solidly the past 5 or 6 years.
Okay, amazing. 20 years. We have so much that we can learn from you. That's just amazing.
My age.
And no, not at all. And I actually was going to ask you, and if it's okay, if you could rewind and kind of take us back to that initial journey. Was there anything or a patient or a clinical or anything that had sparked your interest, and how did that grow over time?
Yeah. So I get that question a lot, right? How did I end up in cancer rehab? So really the simple answer is because of my parents. During my first year of PT school, in the year way back 2000, I feel like I need my geriatric anyway, but, the year 2000. So my father was, diagnosed with colorectal cancer. He had surgery to include a reversible colostomy. He had chemotherapy. He had radiation. My mom was diagnosed a year later with breast cancer. So both of them, a cancer diagnosis within a year of each other, both of my years of physical therapy school. She had a bilateral mastectomy with a tram flap reconstruction. She underwent chemotherapy, hormone therapy for 5 years. They're both doing well now, so they're both survivors. I would say they're definitely dealing with some late treatment effects, though, of their cancer treatments. My dad still deals with occasional bowel obstructions, daily bowel incontinence, due to radiation fibrosis in the pelvis. And my mom still has shoulder issues on her right side where she had her more involved surgery. So it was pretty interesting. My parents both had very different experiences with rehab during their cancer journeys. My mom was actually offered rehab right after her surgery as she was getting ready to start chemo. This was actually pretty advanced thinking 24 years ago. My dad, on the other hand, was never offered or had never had mentioned therapy at any point during his treatment or even well into survivorship. So really seeing what they went through physically and mentally during and after their cancer treatments really made me want to fight for rehab to be the standard of care and for this underserved patient population. And I'm sure that probably everybody on this call probably has a story like that, right? So that everybody's been touched by cancer in some way, shape, or form. So I bet everybody can kind of relate to that. But that's really, it just hit me at that hallmark time when I was in school.
Yeah, well, thank you so much for sharing that story. And I don't know if you can connect it, but I know you had mentioned, in the past 5 or 6 years, you have really started to get involved with the oncology population. Even from 20 years ago to now, what are some of the biggest changes you have seen related to oncology rehabilitation and its involvement in survivorship, in treatment, in diagnosis? Like, what do you think about all of that?
Yeah, it's been very interesting. I consider my journey, like I said, this kind of grassroots because when I first started, when I first graduated physical therapy school, I was trying to decide what setting I wanted to be in. And I ultimately landed on outpatient orthopedics because I figured this is where I could potentially try to see more cancer patients. I had a mentor in physical therapy school. I went to Northwestern University and I had a mentor, Tony Sanders, Dr. Tony Sanders, and she, really caught me going with, she was lymphedema therapist and I did my capstone project in that world. So then when I got out, though, I found there was like no resources out there, nothing. There was just hardly anything to help me, guide me in what I was doing. So it was very much, okay, I just got to do this on my own. Like, I'm just going to figure this out. I do think having that orthopedic focus has helped me along my way. I did become board certified in orthopedics. So, kind of moving along that way, I found that, and you guys will probably see this too, the cancer rehab is a lot of you use your use skills from orthopedics, neuro, cardiopulm. You use all of that. It's just that extra layer of knowing the medical management of cancer and how it really applies to be safe. So I think that I knew the tips and the tools from my orthopedics and I knew all that. I just had to fill in the gaps of how can I get the knowledge of how this really applies. So I was piecing together things. It wasn't until really I kind of just was putting things together, again, very grassroots, trying to just talk to doctors and figure out how things worked. And then it wasn't until about 2015 when I was like, you know what? We really need to get a program going. Like, this is just kind of crazy. And I had started to see more and more research coming out at that point and started to be able to find more resources through research. There were starting to be more classes being taught. So I went and did the PORI class first, and just was like, we really need to get this going. And a couple of years later, we had like-minded individuals in our organization, and we kind of started our Revital Cancer Rehab program. And since then, it's just exploded. The research in this area, you guys probably have all seen, and the resources out there have really just exploded in the past really 5 to 10 years, but truly the past 5 years, it's just exploded. And so I feel like much more prepared to be able to treat these patients, and just contribute to that. And it's exciting, and even to be a part of the research and be a part of the resources that are involved and educate others. It definitely was not all at the fingertips when I started out.
Yeah, and even being a new professional in this oncology world, I've only been in it for about 4 years, and I still feel like I am working through the weeds myself, even with all of these resources. But I know you had mentioned you had taken a course. What are some resources that have really helped you, whether it's podcasts or mentorship or anything? Like what have been some of the major things, like if you could tell yourself 5 years ago, I would take these things or I would do these things, like what would those be?
So I actually have found variety. So I have found the best resources are coming from a variety of different sources. So I try to really expand my reach and get my information from lots of different individuals. So I will try to take courses from, I started out with the PORI, and I mean, Julia Osborne's fantastic, and just getting all the knowledge from her. And then as I got more involved, really involved in the APTA oncology section and hearing the big names in research. Anytime somebody was offering a class, I would try to take it either online or in person. And again, a lot of that was going through COVID, so everything was switching to virtual, but I was trying to absorb a lot of those courses that were being offered through the oncology section. And then anything else that didn't on the surface appear to be related to cancer rehab, but I could. So when I was treating my patients clinically, I realized, for example, seeing a lot of patients with breast cancer that ended up having, brachial plexopathy or different things, I would go and seek out, I need to take nerve glide classes, or I need to take, so I would go and take courses that didn't necessarily relate right to cancer, or courses on cupping, or courses, different techniques that weren't billed as a cancer course. But I knew that I could use these techniques for my cancer patients, balance courses. So, I mean, just, I think that's the key if I were to go back. And at first I started to really try to isolate myself to just cancer courses. And quickly I realized, like, no, that's just going to help you maybe understand the medical management. But really, to have my tools in my toolbox, I need to expand and do cardiopulm classes for my cardiac rehab, for my cardiotoxic patients, and my patients with lung cancer. I need to take, again, like ortho classes. So I've really tried to go that route. So if I were to give any advice on that, I would say take your core courses, read your books, your articles. And I think there's some key articles. I'm kind of rambling here, but if you go with, so I will say, even if you're not going to take the board certification yet, there are resources that are put out, like the list of articles, the key articles that have been put out. Some of those are a great place to start to understand where, what are some of the cardinal, I would say key literature pieces that can help you understand some of the concepts of cancer rehab. Um, the textbooks that I actually purchased the oncology, the newer one, the oncology, the comprehensive guidebook for clinicians. That has been a great resource. So again, I think you have to have a blend of your cancer basis and then all your tools in the toolbox. But if you have your cancer foundation, you're going to understand how you can apply all those tools from those other courses to your cancer population.
Awesome. Yeah, actually that's a really good piece of advice. I feel like especially as someone who came out of the residency bubble, we just have so much content related to oncology, which is amazing because you get to learn so much about, chemotherapy and radiation and on all those sorts of things. But then I don't know if you have had this experience where you get to talk to, the neuro specialist or a cardiopulm specialist, picking their brain about certain patients. And that's when you're like, wow, I am learning so much more
Mhm.
on top of this, simple oncology case that is presenting so differently. And I
Mhm.
was even going to build on top of that, even within your, maybe it's your past workplaces or even your current one, do you feel like you have a strong community of people that you can always ask questions to? Or throughout the years when you've had questions, do you have to seek it through journals or through mentors? Like, how do you get some of these questions answered?
Yeah, no, that's a fantastic question. So again, going back to in the beginning, I didn't have anybody. It was me just seeking things out. I was like, I don't know what I'm doing here, but I'm just going to look up how does how does one treat leukemia and lymphoma? I have no idea. I'm going to go look this up. I'm going to figure this out. And okay, let me think now, and I'm just going to figure it out. I don't know what I'm doing, and I didn't have anybody. So until I found some kind of people that were interested, and we were like little study buddies, figuring it out ourselves. But again, once I am very fortunate and very blessed to be part of a fantastic organization where we have built, a whole culture around cancer rehab, and we have huge support systems in place now. Where I mean, we have since trained, 1,500 cancer rehab therapists across the country, and so
Wow.
not only do we have experienced clinicians, but now we have new people coming on that are seeing cases. So we have a lot of, within our organization, we have a weekly office hours where people bring cases. We have a bulletin board where people post cases. We have an ask the expert. We have a lot of internal built in, and that's been a benefit. I do know that there's other institutions out there that have similar things. So I would encourage you all, to really, if you don't have that, try to start it. Like, I mean, I think it's a very good thing to have. And even within the APT oncology, the listserv has been a really good resource because I'm on the listserv for the APT oncology group as well as the lymphedema special interest group. And some of the case questions that get brought up there, I've put questions on there. I learned a lot from that. So I think even within my institution, but also outside of it. And that support has been huge. I feel like my caliber of treatment, my effectiveness of treatment, quality of treatment has significantly improved since I've had that support.
That's really awesome to hear that you have that support. And it seems like you have a lot of people who are there to help you with a lot of those questions as needed. And I think my follow-up question is if people are interested, maybe like they're in an outpatient setting or they're in school or they're still just building that, how do they get started or how would you recommend they get started? And, even to add on to that, like what are some barriers that you have noticed that might stop people that maybe you have some solutions to?
Yeah, no, great. So I think the couple things. So I think if with students, I think it's really key to try to advocate for clinical rotations in oncology if you can, even if it's not a full blown oncology, because I would say even in our company, which is, has one of the largest, like I said, we train 1,500 people. Those 1,500 people do not have a full oncology caseload, right? We are a primarily outpatient orthopedic company. So a lot of it is a mixed caseload. So 1,500 of those people might be seeing, 20% of their caseload might be oncology. The rest might be orthopedic. So some might be neuro, some might be. So even if you see a mix, you can still have that oncology piece. So as a student, I would, and you have any inkling of being interested, I would highly advocate for that. I think one of the barriers in that is if your school has just no idea of where to go for that. And I do think that the APTA has good links for how to find those rotations. Our institution, we have actually I have Melissa Thess on the call now. She's here. She's like our student coordinator too, so she helps people find those rotations within our company. But then there's others. It's like there's hospitals that do these. So I know that the APTA has been working the oncology section has been working to find lists. So if you're, um, you know, you're the people at your school that are organizing the clinical rotations, if they don't have access, you can help advocate for yourself. Go try to find these yourself and bring them to them so that they can connect. So I think that's a really good piece for students. I also think that even if you're a student, just go observe. So if you can try to find where cancer rehabs therapists are in your area, again, even if their full caseload isn't cancer rehab, try to just observe them. So even if you can't get a full rotation, many of our therapists are welcome people to just come and shadow and observe. And I think that even goes for new professionals, right? So even within our organization, we have people that are like, they've been physical therapists for, I mean, 10, 15 years, but they're like, I'm not sure what cancer rehab really is. And if it seems like I might be interested, but I'm not sure. So we have it where they come and spend half a day with me or half a day with one of our clinicians that primarily sees oncology and just to see what it's about. And so I think that's a really good first step to be able to at least observe, shadow, and then that's a great step. And then Lauren, I think you would agree. If you're interested in taking a step further, finding a residency, right? So whether you're a student and you want to go right into residency or a new professional or even seasoned clinician, trying to find something that might work for you to specialize in that route.
Yeah, the tips that you gave are so helpful because I often find students asking me, I'm so interested in oncology, but I just don't even know where to start. Or even my colleagues in the inpatient setting who aren't necessarily oncology specialists, they're always like, I just want to know what it's like to treat in that population. So I feel like that's such a smart idea to shadow for half a day. I've never even thought about that. So I will take that to my hospital and see if we can get that going.
Yeah.
Um, Now, in your experience, have you been in outpatient and inpatient or a little bit of both? Like, what's been your experience?
Yeah, so I have solely been an outpatient, is in terms of because I've actually worked in outpatient orthopedic world kind of my whole career. But again, I have worked with people that are on the inpatient side with this through teaching and through mentoring, but not necessarily direct patient care inpatient. So my world's been mostly on the outpatient side. That's kind of been my space. But I'm also I'm an adjunct professor at Bellarmine University, and then also just signed on for University of the Cumberlands, and so I and also work with a couple of OTs and speech language pathologists here. We have an organization called Cancer Rehab across Kentucky where we're trying to get more access to people across the state, especially in rural Kentucky. So that's the other thing. I think partnering and networking with other professionals is going to be key. But because of that, some of these professionals work in inpatient settings. And so I've been able to learn more about the inpatient world and how that works. And honestly, being able to I think one of the big goals is trying to bridge that gap between how can we transition these patients better from inpatient to outpatient. Because I think that's a huge need, where we can try to do better, even within our own company. We've got inpatient facilities and we have outpatient facilities, and we're not always talking to each other. So it's like, how can we bridge this gap better and have our outpatient therapists understand what happens in the inpatient world and our inpatient therapists understand what happens in the outpatient world so that we can do that.
Yeah, that is such a great point. I guess I'm curious. So have you found that, creating this network with other therapists and other doctors and just establishing that communication has made, I guess, that gap a little bit smaller, or what are you finding along the way? Because I still experience that gap as I think many people do.
Yeah, I am finding that it takes work. It absolutely takes work. But again, this is kind of my passion. But I'll give you an example. So, I do work outpatient orthopedics, but we here in Kentucky at Court, we have a joint venture with an area hospital, right? So we don't manage their inpatient rehab. That is managed by the hospital. So we manage the outpatient rehab. They manage the inpatient, but we work collaboratively together. So I am on as part of my role as a program director, I am on monthly meetings with the rehab director for the inpatient rehab team, as well as the outpatient team. And so we are constantly working on ways where we do in-services for their inpatient rehab team. And then we are working on facilities, even in the EMR, how in their electronic medical record in the hospital, how can the therapist actually make that recommendation for outpatient rehab? So it takes effort. And it's more than just treating the patient. So I think that's the other part of my passion is I don't treat as much in the clinic anymore. I've kind of moved on to this program development, facilitation, education. And as much as I miss the patient care, the hands-on patient care, I feel like I'm having a bigger effect because now I'm working at these higher levels, trying to get more access to care for these patients. And that's a perfect example of it. So working with these teams to be able to say, hey, let's educate so that these teams can work together. So I'm trying to find within my company and within these relationships, joint ventures, and then even outside of it, I've made contacts through KPTA, I go to the OT conferences. I go to the speech language pathology conferences. I go to all these to try to network so that I can find people that work in these hospital systems so that we can all try to be on the same page. And I find the people that like cancer rehab, of course, that's the people I go to. Like, yeah, I like you other people too, but let's find the people that have a like mind. And that's what we do. We just try to like, how are we going to change this? So, I think you have to, it takes work. This has not happened overnight. Again, I've been chipping away at this, but there have been some definite changes made. It's definitely not perfect by any means. We have a long way to go, but we have made some ground, so I think it's been good.
Your patients, I'm sure, are appreciative, or future patients are appreciative for the work that you're doing. Now, for anyone here who might not be super familiar, and I think this would be kind of an interesting question, is there any change in the diagnoses you were seeing maybe 10 years ago versus the diagnoses you're seeing now? Has it grown or expanded? And with that, like, what are the common maybe impairments or limitations that you were seeing in general?
That's a great question. Yes, 100% yes. So when I first started, and I don't know, this is probably a story that a lot of people hear, but it's interesting. I'd like to hear other people's, like people that are new out there, what they're seeing, because when I first got out, it was only breast cancer. It was only patients with lymphedema. That's really all I started seeing. And so I had to, and that's my mom's story too. I mean, she did get referred, after surgery. And it wasn't so much for lymphedema as it was for, range of motion, which I was actually, again, but normally, like when I talked to doctors when I was first going out there, and still today, but when I talked to them, it was like, oh yeah, I know cancer rehab. Yeah, we have a lymphedema therapist. I'm like, okay. But, that is what I was seeing. It was primarily lymphedema and it was primarily breast cancer for years and years and years. And as I started learning more and more about the chemotherapy treatments, the radiation treatments, that turned my brain on. I mean, the pelvic health implications, the sexual health implications of these hormone therapies. It really opened my eyes to have a much more holistic view of these patients and not just treat their lymphedema. And I think so, even within that diagnosis that I was still just getting, myself as a therapist, I started to begin to treat them more and more holistically and had much better outcomes with my patients. Then I think over time, what has happened, thankfully, is we are seeing a shift where, yes, I would still say the lion's share, if we look at our referrals, I could pull up reports. That's what I do. I look at these referral reports all the time. It's still primarily patients with breast cancer. However, we are seeing more and more patients being referred for cancer-related fatigue, for just weakness, deconditioning, sarcopenia. We are seeing more and more patients referred for sexual dysfunction and pelvic health issues. Rehab has started to really take off in terms of not only for our breast cancer patients, but even in the GI world, like we're starting to see, and lung cancer world. So prior to surgeries. So I'm so excited to see this piece of it. Our patients with hematologic cancers undergoing bone marrow transplants, like it's exploding. And I think as the research comes along, we've been able to take that research to the providers and do a lot of education, and they're starting to say, oh, okay. And the guidelines are changing. So the guidelines, we have NCCN guidelines now that talk about rehab. We have ASCO guidelines. All their guidelines are saying this is what needs to happen. So it has shifted. And so I'd be interested to see, with as students and new professionals, what their caseload mix is versus what mine was, 20 years ago. It'd be interesting to see.
Yeah, I think even in live time in these past 5 years of me working at the hospital, treatment and the shift is happening so quickly. And I think that was actually one of the reasons I wanted to do the residency, because I want to start, as you do as well. You've made this wonderful network of people who can help treat these patients because they're living so much longer, and they're being so much more successful, but treating them as a whole person, comes with a lot of different things. And I was curious, over your years of experience, like, are there any uh, considerations or questions or hard lessons that you've had that you're like, I wish I could tell my past self maybe to ask this question differently or do this intervention differently? Like, are there any just like interesting lessons or wise
Mhm.
words that you have for us new members and
Yeah,
new members and students and stuff like
yeah. I think the big one is really to take that holistic approach. I think that is a big thing. I also think um not to be so nervous and scared. So I think that's a big one too. And I still see that with a lot of my students and a lot of the newer clinicians to this is there's such it's almost overload of information now out there about cancer rehab. And so I see this as an educator when I'm teaching my students. It's almost like a deer in headlights, like, oh my gosh, I have to remember all these drugs and all this side effects and all these safety precautions and oncologic emergencies and it's like, oh my gosh. And it almost feels like it can put fear into treating this patient population. And I felt that a little bit as I started. It's almost like when I didn't know a lot, I didn't have that fear. And then as I started to learn more, it was like, oh my gosh, can I really hurt this person? This is really bad. And I think that I would go back and say, no, you are doing the right thing for this person and you are good. We need to challenge them with exercise safely, but we need to challenge them with exercise. They're not going to get better if we don't challenge them. We know what we're doing. We can be smart with this. So I think the biggest thing is to not try to get overwhelmed and know everything, because that's going to just take you down these rabbit holes. Know your basic safety stuff. Use your normal PT brains and just apply the things you already know, and try not to get too bogged down in all the overload of information that has exploded. So I think that's like a big thing that I would say is try not to be fearful. Um, and then the other piece is more of a soft skill. I think over the years, I've learned my communication with these patients has been a couple things. I could go back. I used to get very, I wouldn't say attached, and I still get attached, but I used to let their, I used to let what if something would happen with their disease where it would, inevitably, not everybody, but inevitably if it would progress or inevitably they would pass away or inevitably, the disease changed, it would really affect me. And I think that, I mean, and I think we all probably do if we work with this population enough. I still remember my first patient that passed away. She was my age at the time. I mean, in her late 20s, early 30s from breast cancer. And she had a 2-year-old daughter. And I mean, I'll just never forget it. And it really affected me. I went to her funeral and I couldn't get over it for several days. And I realized, and I think too, both of my parents were living, but I realized like it put into that mortality, like, oh my gosh, this could come back for them. And again, I think if you have that personal touch, it brings it personal to you. So I've realized over the years how to be there for my patient at the moment and be there for them and be empathetic and put their needs first, put their goals first. What do they want to focus on? What are those patient-centered goals and the focus and be a shoulder for them and be that. But then when they walk out of the clinic, I have to almost put that on a shelf and go on and treat the next person. Because if I let that continue to just wear on me and think about it all the time, I can't be the best person in myself to be able to treat other people. So I think that's what I've learned with this population over time is as empathetic as I am, I can't be a complete empath with this population and let it affect me. So I think that's more of a soft skill. Um, but I had a patient to literally today, and I will read you the text. Literally today, She said, please excuse cut and paste. This is my best way to update. I'll hope to converse online more personally soon. Today I checked out of Norton Oncology and am home being served by hospice. Thanks for your support. Hope to see you soon. So it's like, okay, I just wrote back, Jamie, I've been thinking of you. Please know I'm always here if you or your family needs anything. Much love. So it's coming up with those. It's hard, but understanding that piece. So that's what I would go back and tell myself, try not to get too wrapped up in that.
Thank you for sharing that story. I feel like, Dr. Stockwell, I have that soft skill is only something I think in the last 2 years I've really learned how to develop. And I think a common question that I'm sure you get asked and I get asked a lot is like, how do you take care of yourself when you're working with the patient population that certainly has its ups and certainly has its downs? And I think that soft skill is something that a lot of us continue to work on, and it's not a skill that comes super easy, and sometimes it's easier and sometimes it's harder.
Mm-hmm.
And I mean, even outside of work, like, is there certain practices or community or people that you rely on to help support you during these times?
Yeah, absolutely. I mean, it would absolutely be my friends, my family. I do mindfulness, so I will, if I'm having a day where something like that has happened, I will take time to just reflect and try to center myself and do mindfulness exercises. Because there are days when does get overwhelming. And I mean, I'll have moments where I'm listening and my whole world is cancer. My whole world. All I think about day in, day out and hear about is cancer from a professional perspective. So I do have to take time outside of that to say, if somebody talks about cancer, I can't hear it, and you have to do that. You have to kind of say, as much as I go and preach it and talk to people about it, and I'm happy to help people when they are, have a family member or a loved one. Like, I'm happy for that. But sometimes you just have to say, you know what, I absolutely can help you. I just can't help you right this moment today. If it's a personal situation, just because it's like, sometimes you just have those moments where you're overwhelmed. But I do utilize friends, family, support. I utilize, doing social activities, mindfulness, all of that to just kind of help take care of myself.
Yeah, I think establishing those boundaries is so healthy, both in the clinic and outside of the clinic. But even on this topic, I have a true false question for you.
Mm-hmm. Mm-hmm.
Um, is is oncology rehabilitation sad all the time? True or false?
Oh, false. That's easy.
False. Yeah. And I feel like, a lot of questions hone in on kind of this, not that it's a small part of the job, but I think there's so many more joyous parts of the job as well.
Mm-hmm.
And I was hoping if you could just share some of, like, I don't know if it's like patients that stand out to you or
Mm-hmm.
moments of success. Like, if you could just share those with everyone, I think that'd just be greatly appreciated.
Yes, absolutely. And I would agree with you. What we just shared is probably the minority, right? So it's so many good stories come out of this. Oh gosh, I have so many. I think that I get told a lot. The biggest feedback I get told a lot is, I wish somebody had told me about this sooner. Like, I cannot believe what all you have done for me. You all have completely changed, my life, made me, so much better. And it's really no matter what stage, even if you get them, even if they're not completely back to where they were before their cancer treatments, um, it's a night and day change for these people. And sometimes you get them back to where they were and better because, so I had a patient who, I won't forget her. She cracks me up. Melissa's heard me tell the story about her because she had axillary web syndrome, which is cording in the axilla after breast cancer surgery. And she would crack me up because she came in and she's from rural Kentucky. And so she has a little accent. And so she's so cute. She would come in and she was like, Audrey, my arm, it's like a cactus. It's like this. I can't move it. It's like a cactus. What am I going to do? So she just cracked me up because that's just how she was. And so we worked on it. And honestly, it didn't take long. It just took like 3 sessions and she could like move it. And she was so grateful. She's like, oh my gosh. And she just raved and raved and raved about how it was just the best thing ever. And then she went on. It was actually very cool. She went on to continue on, and it inspired her to start exercising when she had never exercised before. She started changing her diet when she had never, cared about her diet before. She ended up losing like 25 pounds and becoming healthy. Like it was just really cool to see the lifestyle changes she made and the things that she was able to do just from coming in for her cactus arm, but then how we were able to take it that much further. And so, I mean, that's just an example. I also had a really good story of a patient. I'll just tell one more, and then because I have a million, I could just tell. But I had a patient who really was told that with her neuropathy, that it was just kind of the way she was. It was just, she was just going to have pain the rest of her life, and she was never going to be able, to get back to work because she wasn't going to be able to type. She wasn't going to be able to do anything with her hands. Like it was just kind of the way it was. So we ended up seeing her. It was pretty soon after her treatment finished. And so her neuropathy got a little better, but again, we don't really treat the neuropathy. It's not really going to improve that much, but we were able to get her adaptive things like a voice to text, voice to type, voice to text. We were able to show her, it was me and then there was an OT. We were able to show her different techniques for that. We were able to show her desensitization techniques. We were just adaptive techniques. So we're not even talking about getting her back to a previous level of function, but things that actually are going to make her function in the real world. It was life-changing for her. She wrote this great letter. She was like, I can't believe that I actually got back to work. She's like, I told my doctor that he could shove it. It was great. I mean, I was like, well, we don't need to go that far, but so it was just great. And the doctor then was like, oh my gosh. So he started sending patients. So it was just really cool. So great stories there. But
Our patients, the best. I feel like I'm sure you could write a whole book or I could write a whole book. Like they just crack me up. Now, from this conversation, even from just some of the things I was watching and I was reading, it seems like you've been advocating for physical therapy for a long time in the cancer population, and thank you for that. But I'm just curious if you have any dreams or if you had like any way to detect the future, what do you think will happen potentially in the next 5 years, or where do you see it going in the next 5 years, or maybe even the next 10 years? Like, what are some things that you're like, I really think this might happen, all for just the future of cancer rehabilitation in general?
So I honestly think, the more and more the standards push for rehab, it's inching closer and closer to mandating that so if you think about hospital accreditations, or value-based care, participants that are participating in value-based care, which basically a lot of your hospital systems will participate in like their COC accredited, so Commission on Cancer, or their NAPBC, which is accredited breast centers, right? So there's different accreditations that the hospital systems often have to be considered a cancer center. And then you'll have some of your more independent oncology places, and even some hospital systems will be participating in value-based care. And that's really where things are going, is this value-based care type initiatives. I truly think that with all the standards that are coming out, that rehab is obviously a big part of value-based care, right? Because we can decrease, with rehab, you can decrease emergency room visits, you can decrease falls, you can decrease all these things to keep healthcare costs down. So I truly believe that what's going to end up happening is that when they go to audit these facilities, whether it's a value-based care organization or COC organization, NAPBC, they're going to have to go in and not only see a referral to rehab, but actually go and see conversion rates, like how many people are actually showing up to rehab. And if they're not showing up to rehab, then why? And what are the action plans? Because that's where I'm seeing the disconnect. We're starting to get the referrals coming in more because that they're now new, just even with NAPBC this year, there's some new initiatives out there saying that pre-treatment functional assessments needs to be part of the plan, at least offered, but it's very loosey goosey language right now. So if we can, I think that'll get nailed down further. I think that, things will start to move in that direction where there's going to be mandates on rehab referrals. But I think, and I think it's going to be more than just rehab. I think it's going to be nutrition. I think it's going to be behavioral oncology. I think it's going to be some of these other services that these patients really need. But we're going to be needing to look at access and barriers to care. So what is really preventing these patients from getting our services? Is it finances? Is it transportation? Is it staffing? Is it education on their end or providers' end? And I think that's where the research needs to be going to, is what are these barriers to access? Because we are out there proving that what we are doing is working, but the patients are still not getting the care. The only 2% are still referred, either referred or getting access. So what is actually happening here, and where's that disconnect? And then let's study those and then make action plans for it. So I really feel like that's where things are going to be happening, is we know this is effective. Now, how do we actually, that's where I see it going, is implementation.
Yeah, I think the future is coming quickly, but I agree with you. I think I'm starting to see some of those things happen as well. And I want to thank you so much for answering all of my questions. I feel like I could talk to you probably for hours about all the other questions in the world, but I did want to open it up for the group in case that they had any personal questions for you, if that's okay.
Yeah.
If anyone has any questions, you can just put the little hand raise sign and I can go ahead and unmute you.
Hi, can you guys hear me all right?
Yeah.
So earlier you're kind of talking about there's a lot of uh, information out there, and I'm still a student physical therapist currently. So taking in all this information, they always like to say, drinking from the fire hose. So
Mm-hmm.
I'm just wondering, what's the best way to kind of funnel the information so it's a little bit easier to process it?
Mm-hmm. I think that's a great question. So I think when you're first learning about cancer rehab, um, and I say this, I still think I'm trying, as an educator, I'm still trying to kind of perfect this. I feel like even my education strategies over the years have changed significantly in terms of how we are educating our clinicians on this. Um, I think that in studying myself for the board exams and in reading different like textbooks and how things are organized, going to different courses, going to different things, I have, and again, this is a personal opinion, so this is, I don't know that this is research based in education or not. It would be a cool study to do, to see. But I really think, to your point, there's a lot of information. I think if you can think of cancer rehab, but more importantly, the effects, thinking of more the side effects, the adverse effects of cancer treatment from a systems approach, body systems approach, I think is probably what I'm finding to be much more manageable and understanding, like those bite-sized chunks. So it's very similar to how you're learning in PT school. So it's thinking about those body systems you've got, right? Your integumentary system, your cardiovascular system, your musculoskeletal system, your neurological system, all those systems. Think of them in buckets. And then you can even kind of just think of those adverse treatment effects and you start with the cancer treatment, surgery, go through each one of those buckets. What are the side effects that from surgery, cancer surgeries in the body systems, and kind of organizing it that way. And I find when I teach it that way, it actually clicks better. It's like, okay. And so when you're evaluating a patient, if you're thinking in that way, it goes along really well with the ICF model. If you guys are, you're probably like, as a student, like, oh, I'm so nauseated with this, ad nauseum with ICF. But I am a firm believer that in this population, the ICF model is a huge benefit because it breaks it down. So you've got your body systems and your impairments, right? So you've got your impairments and what body system that it belongs to. And then how does that then affect the activities that that patient is able to do? So if they have an impairment, for example, what are the impairments? But it's more so like they have this impairment or the potential for that impairment. So you have to kind of think, what is their oncologic history? What have they been through in the rearview mirror? What does that cancer treatment look like in the past? And what is looking forward, the cancer treatment that they're going to have? So, and you kind of put it in these buckets, in the different buckets of what are potential impairments that this person could have. And like, so it's kind of like you go into your PT eval with like all these differential diagnoses, like what could this person possibly have? What do I need to screen for? You see what they're coming in for their chief concern, and you're obviously going to be focused on that. But in the back of your mind, you've kind of got these things you need to screen for. So I think that that's kind of how you can organize it. At least you've got all this information, but if you can organize it by body system and cancer treatment, you start there. And then when you get into your eval, you can kind of organize it like, how am I going to test for that? How am I going to screen for that? And then how would I treat for that? And how does those things then affect that person's activity limitations, their participation in societal roles, their ability to work, their ability to participate in society? So I don't know. I hope that helps, but that's kind of how I do it, is in buckets. And I found that that seems to be a better way to understand all of it. I don't know, Justin, maybe I just made you more confused, but hopefully not.
Okay, we actually have a question through the chat. How have you been able to accommodate more complex patients in the outpatient setting? I'm finding it hard to see onc patients in half-hour blocks. Any tips? Does Revital accommodate for situations like this?
Yeah, that's a great question. Yes, it is definitely more challenging. And I think you bring up a good point, because I think it definitely is with oncology, but I think it's with all patients. Like, I think even our orthopedic patients are much more complex these days. There are so many more comorbidities. There's so many more. I think it doesn't matter what patient population we're seeing. Our patients are sicker. So I think no matter what, when you're in an outpatient setting, the challenge is real. And so when you are seeing patients in a 30-minute block, 45-minute block, or an hour block, but you've got 2 or 3 patients, it can be very challenging. So I think that, at least with Revital, in our training, when we're doing our training, we do talk about, how do we manage schedule? What are the best, when does somebody need a more, if it's a complex patient, how can you still, and when we say complex, what type of complex, right? If it's complex in the system or in the situation where they're so fatigued that they can't tolerate a whole bunch of exercise and they need one-on-one skilled, like eyes on them, hands on them, because they're a fall risk. Well, maybe they can't tolerate a full hour. You could keep them there an hour, but you're going to have prescribed rest breaks. So you have to kind of get strategic with your scheduling, and that you could have 2 people that hour, but you have somebody that's less complex with the complex person, and the complex person, while they are resting, then you're kind of with your less complex person, maybe doing your manual therapy, maybe doing your one-on-one, and then you go back but it's prescribed rest. And so sometimes I will have them maybe doing a cognitive task or reading information about managing fatigue, or, something like that. So I will say it takes much more planning, but I don't feel like that's unique to the cancer population as much anymore because I feel like that's all of our patients are so much more complex. But I think it does take some strategic scheduling and planning, and it is a challenge, I think, across the board with with these patients, but I think it's very doable if you can try to work that schedule the way, to try to match up those people that would work well together.
All right, I think we have time for two more questions.
Okay.
We'll go ahead and we'll start with one, Amanda.
Hi, Dr. Stockwell.
Hi.
For those of you who don't know, I go to Bellarmine, and Dr. Stockwell is my research advisor. Love her. So my question actually has to do with research in the oncology community. What in your treatment do you find is a very under-researched area of the oncology section that you believe should not like is underrated, but you think like needs more attention?
Hmm. I think that's such a great question because there's been such an explosion of research. And I think again, I'm going to circle back to kind of what I said before. I think it's a more qualitative research in the sense of what are the barriers to people completing, whether it be completing rehab or completing exercise. So for those of you guys that probably don't know, Amanda and I's project that we've been working on is, the benefits of an exercise program for cancer survivors. And we've done lots of different things, but part of it is, do they do better supervised, unsupervised? I think in general, would be very interesting and is not looked at enough is what are the barriers to the facilitators and barriers to these patients being able to either attend therapy or complete their therapy or complete a home exercise program or meet the ACSM physical activity guidelines, right? So we know that those are absolutely beneficial, but we know that nobody meets them, and especially not cancer survivors. So I think more qualitative research is needed in the sense of like, what are those barriers so we can get a handle on that. So then we can go back and try to test the implementation science of what's going to work to overcome those barriers. So that's where I would say is we're at that point where we know a lot of our interventions work. We need to know why these people can't get to us to get to our interventions.
Okay, we have really quick, a few more
Yeah.
questions. We have one more through the chat, and then Amanda, why don't you go first?
So I was wondering if you think there are any specific times for like a structured referral process. Like I know my clinic, we have a breast cancer program, and we have patients come see us before surgery and then after surgery. Do you think that there's any other opportunities like that to say like at this point in this patient's treatment, they should go to see the physical therapist, obviously aside from anytime that they feel like they should.
Yeah, absolutely. So that's a lot of kind of what we're working on is putting into place, certain protocols of when they should come and having it be standard of care. So your example is right on. And where we are getting a lot of traction is because there's more research is always done in the breast cancer population. So we're getting more traction in that patients need to be coming pre-treatment. So pre-surgery, whether it be pre-surgery, pre-neoadjuvant chemotherapy, because they need to be getting baseline assessments. And it's not just patients with breast cancer. So it really needs to be anybody, ideally, starting a cancer treatment. And I get that it's probably not feasible for every single person to be referred. We don't have the bandwidth for that. We can't see every single person. We don't have that. So criteria need to be in place for who is maybe high risk. So who are more the high risk people? So we can look at comorbidities. We can look at determinants of frailty. We can look at different things to say, at the start of chemotherapy, these people really need to be coming in to be assessed for, are they frail? Are they at risk for functional decline? And they need to be put on a plan to help maintain their function during their cancer treatment. So I would argue that no matter what the disease state, that if you've got, and again, this is where a challenge comes in, because how much can they do at the doctor's office to really determine that frailty? We know that the ECOG is not great for that. We know that it's just very subjective. So there's a lot of different things that need to be done. So I guess, Amanda, there's your other area of research. What can we be doing to actually screen and test for who needs rehab at that moment, or who would benefit the most from a prehab referral, or so that would be a good test as well. So I do think that point. I think anybody going in for any type of cancer surgery could benefit again from, so lung cancer. There's been a lot of research out there on prehab for lung cancer, GI cancer. Those patients tend to have neoadjuvant chemotherapy. So again, and they decline and then they're not ready for surgery. So yes, I think all to say, we know that there's different disease sites that have certain treatments that set them up for functional decline. And I think every single one of those is an opportunity to set up a protocol within your institution or within providers that you work with to get a process in place. And so that is such an opportunity. And if you can be the one to start to implement that and try to work with those providers on that, that's going to really push our push it for standard of care, I guess.
Thank you. Okay, we have one last question and then we'll end it here. How do you best advocate for yourself in cancer rehab as a cancer rehab specialist when the field is still growing and there isn't necessarily a seat at the table when it comes to cancer care continuum, in both terms of advocating and educating patients and providers?
You gotta have tough skin. It's tough, and you gotta be willing to just nag. No, I'm just kidding. But you do. You just have to be. You have to be resilient. I think that's the other thing that I've learned in my career is I have really built up resilience, grit, um, perseverance, and not to take things personally. I've had to really grow in that. I really have had to grow in that aspect. I used to be very intimidated by physicians and just feel like, oh gosh, they must know so much more than me. They don't. They don't in this realm. They do. They do in how to manage a cancer. I am not the person to know how to figure out which drugs to prescribe somebody to get rid of their cancer. That is not me. I don't know the radiation field to prescribe. That is not me. But in terms of rehab, I know more than they do, and you know more than they do. So you have to understand that and be confident in that. And even if you have to practice in front of a mirror and do hype songs before you go into these meetings, and I sit on tumor boards and I have to hype myself up and I have to be like, up. And at first they were like, who is this girl? And why is she there? And what is she doing? And now they just are like, oh, Audrey's talking again. But you just have to be that, squeaky wheel. Like you have to just be the squeaky wheel. And so over time, I've built that confidence, and it's tough, but you just have to advocate and keep pushing and get out there to your communities and spread the word to the patients, because the patients will then go back and tell their doctors. So anytime you have a good experience with a patient, take that. This is how I built it. I literally built it grassroots. Take those patient experiences, write a letter, take it to their doctor, and not only the doctor that referred them, find out every person on their cancer care team and take it to them. You take it to their medical oncologist, their radiation oncologist, their surgical oncologist, their primary care, and you go and you say, look what your patient did in rehab, cancer rehab. Even if they're not the one that referred it, get your patient's permission first, but go and take it. And that's how I built it. It's like, if you build it, they will come, hopefully. You just keep going. And it's like one patient at a time. So even if you feel like, I'm not the person sitting on tumor boards, I'm not the leader, I'm not a program director, doesn't matter. You literally start one patient at a time and you can make a huge difference.
Thank you so much. I think we'll end it here. We really, really appreciate your time and your volunteering to come and chat with us. We are hoping to make this series or this webinar a regular thing. So hopefully everyone who's joined, we appreciate your time as well. And we'll stay in touch in regards to any future events. Thank you so much. It was really great.
And I just wanted to say, if you guys want to learn more too, and again, like if you guys want to learn more information, we can put in the chat just a link that you guys can click on. So if you guys want to learn more about cancer rehab, do that. I'm also going to put my email in here. So you guys are totally welcome to reach out to me at any point if you have more questions about, Revital or cancer rehab in general, because I'm involved in a lot of different things outside of Revital.